part is, I only got to know yesterday morning, Vishnu is sitting there, that this is really happening on 2nd, which was very softly, kind of passed on to me. When the program on the 23rd was cancelled, he said tentatively it would be on the 2nd, and I thought he said, and I didn't remember. Last night I spent in Shantiniketan on a very interesting trip. I went and I reached Shantiniketan at 11 o'clock, and this is the first of its kind, like a Shottayitra movie, kind of a detective serial. I was supposed to, close my eyes and get inside a room where a foreign diplomat was being treated without the government knowing it, and neither did I know where I was. And and in fact, I set the regimen there, the insulin regimen. It was completely bizarre. I mean, it was 440 with 40. That was the amplitude of excursion. And then I was supposed to stay back and then brought back to proper whole food for a good lunch, and then back home. And I have a meeting. I have a lecture again in Raichur. So I left at 9 o'clock, and this was the material. And I had some materials from long back, which I had rummaged and started making in on the trip in the car. Unfortunately, the laptop, as old as me, ran out of charge, and this is the last bit which I did there. The thing is, why we are here today with me is basically talking about analogs. We know about insulin, we know about the normal, the regular insulin that we had started writing when we were in school. And then the NPH came, which is a longer duration, which was mixed with the the short acting or the regular ones, and this combination was also in vogue for a long time. Then suddenly, by the end of 1990s, which was 1995, 96, Lispro came, and then Aspart came. These were just trivial amino acid sequencing changes in the regular regimen of the amino acid sequencing that was originally discovered by Banting-Shire. And we have small changes to make it work better. And how do they work better, and why do they work better, is basically the crust of today's talk. Now this is what we know about. This is Skylar. This is Skylar and the Charybdis. Now these were the two Greek monsters. See, this was Skylar. Skylar is, if you're navigating the boat very, very casually. This was somewhere near the Strait of Gibraltar on the Mediterranean. You're getting inside it. It's from Sicily towards Italy. This is the place where you have this kind of a, this is a kind of whirlpool kind of thing which draws you in, sucks you in, and there you have, which is just close to the creek and the mountain clear. You have waterfalls and other things coming down suddenly without any notice. So this is like, they called it the journey through the narrow channel between the Skylar of uncontrolled hyperglycemia, and if you're just not careful, you slip into this hole. So this is hypoglycemia. So this is one of the wonderful depictions of Greek mythology, which can be attributed to the present management of diabetes. In fact, the age-old management of diabetes. What we are lurking behind is to get a control of that. So last night, what I saw was 446 and also 40, and exactly that is what is talked about here. So how do we get a better control? Now we know the global projections of diabetes from 2010. This is just going steadily. It's a complete linear acceleration. We know about this epidemic. We know that we in 2011, November at last, it was said that we were 61.3. Then we realized in 2012 we were 63. Now we believe we are 64.5 by March 2030. And it is projected to be 100.2 in 2030. I'm sure this 100 would be, we would proudly achieve this 101 by 2025 or 23. Because we have seen that the projections that have been portrayed down the timeline have all been shortened, have all been narrow, and we achieved the targets pretty soon. And this is quite embarrassing. Now this is diabetes and pre-diabetes in urban and rural India. This INDIA study is a good study which is going on, and as on date, this is published in 2011, and this is Anjana RM, remember Anjana's paper which says that it was 62.4, which is now 64 nearly. And this was 77.2 pre-diabetics, that is IFG or IGT. I believe we know that what is IFG and IGT. IFG is the number between 100 to 125 in fasting state, and IGT is if you're given a postprandial glucose load of 75 grams, then just at 2 hours, if it is within 140 to 199, that is pre-diabetes. Now they have talked about very gloriously today, because it has been shown that pre-diabetes also runs the similar risk of all the macro and the microvascular disease. So we now do not know exactly when that ticking clock starts, whether it is at the onset of diabetes diagnosis or whether it had started 10 years back, before actually diabetes per se started playing its, wreaking its havoc. Now, this is the state where we are in this country at the moment, and this is also, with the underlying not so proper census mechanism that we have. So let us come down to, and we all know that 50% of the pancreatic beta cells are not working at the time of diagnosis. In fact, almost 80% of the mass is gone at the time of diagnosis. So we know, despite the hardest effort of putting in one oral anti-diabetic drug, then up titrating the dose, then again adding another molecule, perhaps in that time frame of say 5 to 7 years, maximum 10 years, you need to actually bring in insulin. The point is whether the earlier is better or late insulin insertion is good is a big debate. But as of now, the big data, the whole robust data talks about early insulinization, when the cellular memory, the legacy effect of the better control actually helps you to prevent complications in the long run. So therefore, insulin therapy is to be thought about earlier. If it is so, then what it does, it aims to replicate the normal physiological insulin response. And what is it? It will depend on the type of diabetes the patient has. It will depend on the willingness to inject. Patient has a lot of phobias. Patient has a lot of myths to live on. So you have to kind of basically clear that gloom and swipe the dust. Have a clear passage of thought, clarify all the issues, and then make him understand. Then there's a lifestyle. You have to drink every evening, and then you have to also munch chili baby corn. If that is so, then you have to again take care of that. Like blood glucose monitoring is a very, very important issue. If you're talking about insulin, I always pledge these companies that whenever you're talking about insulin, it costs peanuts actually to give a glucometer along with you, because if he's an insulin member, he's actually a lifelong member. That's the question, or that's the problem that the patient has in the head. They come and say, frankly speaking, if he's not in state of intercurrent illness or some kind of unstable state where he requires insulin only for that time period management, otherwise he is better off with insulin lifetime management. So if we could give him a glucometer, tell him the techniques of it, very easy techniques, and train him, then life becomes easy for him as well as us, right? Age, old age, the HbA1c, whether it's 7, 6.5, those issues, dexterity, what kind of job and how well he can adapt, and the glycemic targets individually. This is, the human insulin's the action profile that we all knew. Actrapid, which is the one which we commonly use in our hospitals, is given pre-prandially, which has the onset of action almost half an hour, before the meal. So we give it half an hour before the meeting, and